Good. Okay. Well, a very warm welcome to Bush House and to the Policy Institute at King's. So my name is Gareth Owen. I'm Professor of Psychological Medicine, Ethics and Law at King's College London, and I'll chair this evening's event on assisted dying, principles, practice, and politics. Now, this is the state of the world in relation to assisted dying. This comes from a recent Health and Social Care Select Committee report. And the main thing to point out here is that we're increasingly discussing it across jurisdictions, and we're increasingly enacting it in law. Now, this map may make you think that the whole world is in fact enacting it, but of course it isn't. The majority of the world isn't enacting it at all. So it's in relative terms still quite a sort of niche area of legislative activity, but it's definitely increasing. Now, the main thing about the different models of assisted dying internationally is that they're significantly different. So the ones that we're most familiar with, Oregon, Canada, the Netherlands, have all got very significant differences. So when we're talking about assisted dying, we're not talking about one thing. Now, here we are in the UK. Of course, we're more than one nation. The Scots have got their bill in Holyrood, in the Parliament there. And just today, we have a bill in the House of Commons. This is Kim Leadbeater's bill. So discussing this today really couldn't be more timely. So we're going to be seeing Parliament in action in the coming months. Now, I should give just a bit of context about this, this event. Assisted dying is a complicated area. It's emotionally very complicated and demanding. And one's always coming from a point of view or for a stance. So our group, and we're called the Complex Life and Death Decisions Group, is a research group where we go across public policy, psychiatry, palliative care, law and ethics. And we're interested in complexity. That's really our interest, and that goes back, in fact, to a public deliberative study we did during the COVID pandemic on age and access to ventilation or intensive care, so the issues around triage. And we also have an interest in complexity or complex questions in mental health and mental capacity law. So in a way, that's really where we're coming at this from. We're interested in complexity. And that's our theme tonight. And rather than pro or anti arguments. So we want to explore the uncertainties in implementing this kind of law reform and the nuance, in fact, in public opinion, as well as intricate issues around consent and safety. So we'll start tonight with presentations on some new polling data. We've just completed a study on public opinion. And then we're going to move to a panel discussion, and then we'll have an open discussion and finish with a chance for some informal discussions over a drink the other side of the floor here. So please let me introduce Professor Bobby Duffy. Bobby's the director of the Policy Institute, part of this research group I've mentioned, and he's going to talk us through the public opinion data.
Yeah, thanks very much, Gareth, and good to see so many people here for this session. It'd be lovely to say that we planned this to be happening just at the same time as the bill comes through, but we didn't, as you'll see from how we've done the fieldwork. We did a study in England and Wales on public opinion on assisted dying, the principles and practice. It was mid-September, so this is still new data, and it was a representative sample of 2,000 people across England and Wales. And You've got your packs, so I'm not going to go through all of the detail of the packs. I'm going to try and pull out 5 key points in the 10, 12 minutes that I've got for this. And the first is the big picture on this, is that 2/3 of the public say they want assisted dying legalised during this Parliament. We asked a whole series of questions about legalisation and the principle of assisted dying, and the support for assisted dying in principle, support for legalising it, support for legalising it in the next 5 years, and then we had the Lord's Bill specifically that we were looking at, which I'll come back to later. And the picture across all of those different formulations is pretty consistent. About 2/3 of people say they do want to make assisted dying legal, in this case in the next 5 years. 1 in 5 people, 20%, say they don't want that to happen. And there are some variations by subgroup, which we find in other similar sorts of studies. And it's actually just worth noting that it's not young people particularly in favour of this, it is older people. And that goes a bit to the fact that it tends to be related to your experience of this, the closer you get to this being a real type of thing for you, either directly or through family and friends. And then another factor that you see quite often in these types of studies is it's related to ethnicity, with people from minority ethnic backgrounds less supportive, which may be related to religion or other factors in their background. We also had the fortune of asking whether people would like their MP to support it or whether they would like them to oppose it, or whether they should follow their own conscience. And this is the pattern you get when you ask that type of question, with this box being the difference. You got 3 in 10 people saying that they would like their MP to actually follow their conscience. And if I just flash up the support, the overall support figure that I've just shown you, you can see that seems to come from all sides, that people move towards actually my MP should just follow their conscience. There's a proportion of support, a proportion of opposition, and a proportion of people in the middle that say this is actually a matter of conscience. So good that we've got a free vote in Parliament on this. And then the second point I wanted to make is that there's many strong reasons given very widely by supporters for supporting assisted dying. So this is the people who said they support legalizing assisted dying and how important different sorts of reasons are for them. And you can see top one is it could give a less painful or distressing death for people, and very high proportions of people saying that's very important. That's a very important factor, 85%. But that's a factor, that's a feature across all of these types of responses, that it could give people more dignity at the end of their life. Very high proportions, again, saying that's a very important reason for them. The sense of choice is very important in lots of the data that we will see in this and other studies. People being able to choose how and when they die is an important motivator for people supporting this. That people who are terminally ill will be better able to enjoy what time they have left. Again, 7 in 10 people strongly saying that's an important reason, very important reason for them. And then it's wrong that people have to travel to other countries like Switzerland to receive an assisted death. Again, very high proportions of people saying that's an important or very important factor to them. So a whole range of different types of motivations that people give for it. This list goes on for quite a few, and I'm going to show you the bottom ones. So these are the ones that are less emphasized by people. About saving money for the NHS is the one that comes out bottom on this, but it's still a majority of people saying that that is an important reason for their support. That it can be less burdensome for individuals, families and friends. That we're drawing into, bringing ourselves into line with other countries like Switzerland. Again, further down the list, but still significant proportion. But it's these two that are quite interesting, and just reflecting on that theme of it's that direct experience. We do often find that people who've had that direct experience, either through family or friends, of going through difficult deaths, that they've got higher levels of support for assisted dying generally. But then this one is particularly interesting and may come up more in the discussions, that it's also important, it comes up as an important reason for large proportions of the population of supporters, that palliative care is often not good enough for people. So you can see the interconnections between assisted dying and palliative care, and I'm sure we'll discuss this more, and having to see palliative care as part of the package of any type of discussion around assisted dying. And you can tell from Gareth's introduction and all the discussion around it, is that many of the public have strong views on this, but it is also the case that most of the public are less certain in it. So this is where we can look at the question that we asked about Lord Falconer's bill. So we knew about Lord Falconer's bill when we were doing the fieldwork, so we could kind of summarize it in a bit more detail and put that to people. So we picked out the key features within the bill that they can request. People can request the medical assistance to end their life if they have 6 months or fewer left to live. They have the mental capacity to decide. That the request needs to be approved by 2 independent doctors and a judge, and that individuals would need to self-administer the medication. And then we put a bit of a sense of the pros and con arguments that people are putting to it. And when we put this to people, we get, again, incredibly similar levels of support to the principle of making assisted dying legal or making it legal in the next 5 years. So you've got 66% of people saying they support the bill. But as a survey pollster over many years, whenever you see studies like this, you do look much more closely at the strongly support than the tend to support. Because that's a real indication of people who've got a strong view on this. It means much more than tend to when people respond like this. And you can see a large proportion of the population, 35%, just over a third, saying they strongly support it. A lot fewer, 8% saying they strongly oppose it, about a quarter at that level. So that's the first point I take from this slide, is that there's strength of feeling on either side among minorities, particularly on the support side. But then I also take this point, which is when you add up those people in the middle who tend to support through neither supporting nor opposing, don't know, all the way through to tend to opposing, that's 57% of the population. So you've got over half of the population who haven't got that strength of view. So it's still a bit open for big chunks of the population. So then if we switch from reasons for support to reasons for opposition, they're mainly about 4 things I would kind of group together from our survey results. Mainly about pressure, principle, complexity, and creep is the themes that you'd bring out. So again, a number of dimensions. This is asked of that smaller group, the 15 to 20% who say they oppose legalising assisted death for terminally ill in England and Wales. And the top answer given from those who do oppose is that vulnerable people could feel pressured into choosing an assisted death. But then there are quite a few items that come quite high up in this list, whether people think it's just wrong to take a life under any circumstances, or that health professionals are often quite linked to health professional relations. Health professionals should save lives, not assist in taking them. Comes up high, and it could reduce trust between patients and health professionals is another element of concern. And then on the complexity side, people just saying directly there are too many complexities in practice for it to be safe, or that people may change their minds too late, that this isn't a static kind of decision. And then finally, the creep, the sense of creep one, which you get large proportions again saying that this is very important to their opposition, is that once we allow assisted dying for people who are terminally ill, we will end up allowing it for conditions that are not terminal. And that's, again, I'm sure something that will come up in discussions as we go through. We did also ask this of the whole public. Which of any of the following groups do you think are most at risk of being pressured into choosing an assisted death? And it was interesting, from that list, it's actually people with mental health conditions that people put top of that. Maybe a bit surprisingly compared to older people, people with disabilities, chronic long-term health conditions, or with a cognitive impairment. And this may be some of the stories that people have been seeing more in media about the links potentially to people with long-term mental health conditions. So a sense of who could be vulnerable and why people would want to protect that. And then we also asked this question, which it takes people to the future, that in the event that the law is changed to allow assisted dying in England and Wales, how likely would you be to change your mind to opposing rather than supporting? So this is asked of people who support assisted dying, if the following occurred. And the first one was around that sense of pressure. It turned out that a person had been pressured by someone close to them into choosing assisted dying, and you get 55% of the supporters, saying that actually that may make them choose their minds. They're very likely or fairly likely to change their minds as a result. And the second one is it turned out that a person chose an assisted death because they could not access the care and support they needed. Slightly fewer, 48% of people saying that that may change their mind among this supporter group. And now, again, as a survey researcher, you're always slightly cautious about putting people into a projected future where something has happened and thinking about how will that affect your thinking. So you have to be cautious in how you interpret these types of things. But we toyed for a long time about the different questioning approaches to try to get that sense that opinion may not be stable depending on how this plays out in practice. And you can see there is potentially some instability depending on how it actually goes. So fifth and final point I wanted to make was just we did go through, and there's much more in the pack on this, on the practicalities of how it should be delivered. Basically, people's views is it should be available on the NHS if it is passed as a law. It should be available privately and where people choose in terms of practical administration of it. So if you ask people if assisted dying were made legal in England and Wales, which of either of these would you agree with most? You get 6 in 10 people saying that assisted dying should be accessible as part of the NHS, only 1 in 5 saying it shouldn't be. And then if it's made legal, should private healthcare companies also be able to provide this service? A pretty similar pattern. People are pretty open-minded to NHS provision as well as private provision if people so choose. Where we're less clear is about whether it should be free to people who choose an assisted death, so they should not have to pay for it themselves, or whether they should have to pay for it themselves. It's still more people saying they should be free, but a lot more people in the middle. This is, again, one of those things that people probably haven't thought as much about at this stage in the process, and will be something that would need to be thought through more. And final data slide from me on this, just about where it happens and how it could happen. So again, thinking in the scenario that assisted dying is made legal in England and Wales, assisted death should take place in specialist clinics dedicated to that purpose. Public not really keen on that, just 35% saying that should be the case, a quarter saying it shouldn't. But these two are interesting together, whether assisted death should take place wherever a person prefers, whether at home, in hospital, or in a hospice. You get high agreement with that again, that sense of choice, that this is about choice and control for people. So being able to choose where it happens would be important to people. But then on the other hand, people also say that a healthcare professional should remain with the person after they've taken the drugs until they have died. And there's clearly going to be some tension, at least, between those models, that having a healthcare professional there for all of that time, if the choice is to have this at home, is going to be a challenge for health services. So lots of things going on, much more in the pack that you can look through at your leisure. I suppose just 4 points from me before handing over to the panel is that I think what we can take from this data is that general support is pretty clear across all the different ways in which we've asked this, but then so are the complexities and nuance in public opinion as well as the issues themselves. There's more going on here. In that sort of context where you've got high level of support, but also some sense of complexity, I think it is absolutely right that it's going to be debated in the Commons. That is great. And I think it possibly also possible to make the argument that it's right that there should be public deliberation on this too. Citizens' assemblies, citizen juries type exercises. There's been some great examples of this in France, doing citizens' assemblies, citizens' juries in Jersey, and in England, run by Nuffield. And really useful exercises where people are not just asked their opinion in these types of surveys, but are taken through the complexity of the data and the expert opinion on this, and then allowed to judge on it. And even in the scenarios that we've got in front of us, either the bill is going to be passed or it's not going to be passed, but you can see roles for public deliberation in either of those scenarios. If it's passed, we've got still a lot to sort out in the complexities of how it is administered and done. And if it isn't, then thinking about how do we bring the public into that, if this is something that the public support. One final point on that, is you do seem to see in the public deliberations, the assemblies and the juries, that actually when people go through, the public go through that type of exercise, a more in-depth assessment of this, they come out more or less in the same proportions of 2/3 in support when they come to the end of it. So people can take on that complexity. It does help inform their views, but it doesn't change that picture massively overall. So thank you.
Yeah, good. Multiple hazards on the stage here. Well, thank you, Bobby. That really helps set the scene, give us the context on public opinion. So now we have a panel, and then I can't really say anything other than I think it's an extremely interesting panel. And I'm not going to be able to introduce everybody properly, so I'm going to ask everybody all our panelists to introduce themselves, and then they're going to have 5 minutes to talk, and then once that's complete, we can have a discussion and a dialogue. So, Catherine.
Thank you. Do you want me to introduce myself and then speak?
Please.
Yeah, thank you. Can I be heard? Yeah. So my name's Catherine Sleeman. I'm Professor of Palliative Care at King's. I'm also a consultant in palliative medicine, so I practice clinically at King's College Hospital. And not surprisingly, I'm here to talk about palliative care. So palliative care is about improving quality of life for people who are living with life-limiting illnesses. Palliative care focuses on understanding and improving physical symptoms, things like pain, but also addressing psychological, social, and spiritual concerns. About 3/4 of people would benefit from palliative care before they die. But there's a big gap between the number of people who need palliative care and the number of people who get it. Hospice UK did a study a few years ago where they estimated that more than 100,000 people die every year in the UK needing palliative care but not receiving it. And I see the consequences of this gap in my clinical practice. So people whose symptom control is way off what it should be and could be, people who have existential distress but haven't had anyone try to unpick that with them and help them with it, people bouncing in and out of hospitals because no one's asked them what's important to them. And it does worry me that legalising assisted dying in the context of what we know to be patchy and variable palliative care services will lead some people to choose an assisted death because they can't get the health and care and support that they need. And that's not really a choice. Now, I know that no one in this room is going to disagree that we need to improve palliative care. But how much really do we care about improving palliative care? We know that provision is inadequate, we know that provision is unequal, but I've been saying these things for a decade. When most people think about someone who might be affected by an assisted dying law, I think the sort of person who comes to mind is probably someone like Esther Rantzen, who's been in the press so much, someone who is quite confident, quite articulate, and is able to make their wishes known. When I think of someone who might be affected by an assisted dying law, I think of my patients. So I work in a part of London that's very ethnically diverse, very socio-economically deprived. The average reading age in our patch is 9 to 10. My patients have not had many of life's advantages, and many of them are old and quite frail. They may have fluctuating capacity. They all have good days and bad days. They all have moments of hope and moments of despair. What impact would an assisted dying law have on them? We've heard that about 6 in 10 members of the public feel worried that some people might feel pressured into an assisted death. I agree with that. And I think it's at best naive to say that the decision to have an assisted death would never be influenced by external pressure. Maybe not for some people, maybe not for people like Esther Rantzen, but of course for some people it would be. And the thing about coercion is sometimes it's really obvious. But what about when it's not? How do we even detect it? I don't know the answer to that. What I'm not saying is all we need is good palliative care. As long as we've got perfect palliative care, then no one will ever be looking for an assisted death. What I am saying is that there are also people in our society who are at risk of being pressured into an assisted death, either by the people around them or by the system which is failing them. And we've barely scratched the surface of understanding who they are, how at risk they are, and which safeguards would reduce those risks to levels that we as a society would find acceptable. I know, of course, that for some people, legalisation of assisted dying will bring peace of mind, it will bring comfort, it does offer a choice, a true choice, that is very welcome. But I also know that the risks of coercion, they are real. So we need to go into this with our eyes open. Anyone who says we can draft a law that will be 100% safe doesn't understand clinical reality. We know who will benefit from assisted dying. We now need to give full consideration to those who will be at risk, shifting the debate away from is it morally okay, yes or no, to these much, well, in my mind, much more complex, much harder questions. I would like, ideally, never to hear again the phrase, with appropriate safeguards. What I want to know is which safeguards are appropriate, how safe are they, and how safe is safe enough. We have to ensure that the law works for everyone in our society, including those who have had fewer of life's advantages.
Thank you, Catherine. Alex.
So, hello, I'm Alex Ruck-Keene. I'm a professor of practice at King's. I'm also a barrister at 39 Essex Chambers, so I wear two hats. And a professor of practice is a professor, academic professor, who is trying to think about matters of practice and policy. And so I really debated long and hard about whether I should come out at this session, but I'm going to. Because I was actually a barrister, I fought for many years a long case about assisted dying. I was one of the team acting for Noel Conway in the last serious, substantial case challenging the ban on assisted suicide, all the way up to the Supreme Court. So I put my professional heart and soul into that case. I absolutely did. The courts rejected that challenge. They made it clear it was a matter for Parliament. As I said, I put my professional heart and soul into that case. I never had the slightest doubt that my client was individually deserving of assistance. I never had the slightest doubt that he would have satisfied the criteria for assistance which were being put forward, which are essentially identical to those being put forward in Lord Falconer's bill. But the longer the case lasted, the more I had a lurking feeling that that wasn't really the issue. Because the issue is not the individual case, and it's not the principle. And I just had an increasing list of questions. And I still have these questions, and I'm going to go through some of them. I'm going to abuse this opportunity to go through some of these questions. They include, but are not limited to, as lawyers like to say, the following. If law has to operate for everyone, how can it meet the needs not just of those who want to make a choice, but feel they have no choice? What's the appropriate legal response where the person is not coerced, but it wants to make the decision because they feel a burden? Not clinical response, but legal response. Does the conventional approach to capacity work? So normally we have a presumption of capacity. Do we presume that people seeking an assisted death have that capacity? We normally try and support people to make their own decisions. Should the doctor be supporting somebody to make a decision to seek an assisted death? I should say that is a question when I ask many people, they go, I hadn't thought of that. That has some big implications either way. Can the concept of capacity itself really do the work it needs to do when we've got lots of evidence that it doesn't really do that job very well in lots of other contexts? I spent the morning training doctors on capacity, consultants on capacity. And I can tell you, dedicated professionals were asking me questions about capacity 17 years into the Mental Capacity Act, which were concerning me. That's not unusual. And then rather more metaphysically, or if the point of change in the law is not just to get out of the way of willing doctor and willing patient, but actually to provide meaningful access to people who want help with death, what does that law look like? So it's not just saying we're going to legalise it, because you could just legalise and say that's it. But if people actually mean that they wish assistance, what does that mean? Does that have to be provided through the NHS? What happens if patients can't find a willing doctor, assuming it forms part of the healthcare system? Should people be asked to pay? Should they be asked to pay for the relevant medical reports? Or should this be NHS free at the point of service? If people have to apply to court to confirm their decision, what exactly is a court going to be doing? Is the court just going to be looking at the paperwork and saying, yep, that's the right person's name, I'm going to go ahead? Are they just going to hear from the person, or is the court going to have to appoint someone to test the evidence? Who's going to pay for the privilege? Being really flipped for a second, are people going to spend the tens of thousands of pounds that they're not spending on going to Dignitas on fees for people like me? And these are real questions. And then how will monitoring work? And how will we know if the law is working? So these are all questions. I've posed them as questions. I completely and utterly believe that the House of Parliament needs to make this decision, in the sense that this is not a decision for courts. But Parliament needs to be doing this on an informed basis. And I have to say, I would want each one of these questions, I would like an answer to before the bill leaves Parliament, not after the event and people are trying to pick up the pieces. It will keep people like me in business for years as lawyers. That is not what you want. We need to try to work out the answers to these questions before rather than later.
Thank you, Alex. Anna.
Thank you so much. So I'm Anna Dixon. My own professional background has been in health and social care, where I've worked in both research and policy. I worked as Chief Executive of the Centre for Ageing Better on a wide range of issues affecting older people, including ageism. And most recently, I chaired a commission for the Archbishops on the future of social care in England. I must also declare an interest. I've been latterly working with Catherine here on the banner behind her, the Impact Centre on Palliative and End-of-Life Care, which aims to ensure that policy and practice are informed by evidence. And I guess it's from this experience that I just want to share a few observations. But obviously, you'll also see that I'm Anna Dixon MP. I'm one of the new intake of Labour MPs for my home seat of Shipley in West Yorkshire. So coming in as a new MP, it was evident that we were likely to be debating a bill on assisted dying in this Parliament. But obviously the timing of today's event couldn't have been more prescient. I was in the chamber earlier today when Kim Leadbeater introduced her private member's bill. And in just over a month's time, the bill will have its second reading and first substantive debate. While this is an extremely emotive subject, and as we've heard today, a minority of people hold strong views at both ends of the debate. It seems clear that the majority of the public, and I think perhaps MPs like myself, this matter is far from cut. And I think, like many others, wish to give it careful consideration and weigh up the complexities, understand the practical challenges of implementation before making up my mind. And so today's discussion is an incredibly important opportunity to do that. So the first observation I'd like to make is around access to care and support. As we all know, there is a current lack of access to care and support. Millions of disabled adults and older people don't have the access they need to have a good life. And I could make some political points about cuts to local authorities, but you know, it has been a failure of reform over many decades to social care that's left us where we are today. And certainly at the moment, social care isn't there when people need it. We were debating earlier today about family carers, and the reality is that the burden of care falls to families and carers. And it does mean that people can feel a burden to their families. And I worry that this likely puts either direct or indirect pressure on people to consider an assisted death. And so I guess I'm flagging a risk, a significant risk, that implementing assisted dying in a context where people cannot access care and support, and where in particular the costs of care fall to families and individuals. 24/7 care, 6 months of life, that is your inheritance. So that's sort of one thing that's a concern. The second is around something that Catherine's touched on, which is the unequal access to palliative and end-of-life care. So just in this Parliament, 3 million people are estimated are going to die in the UK. As we've heard, there is a massive gap between the need for palliative care and those who receive it, estimated, as Catherine said, 100,000 people each year. For me, though, more importantly, the people who are non-white, older, from lower socioeconomic groups, and those with conditions other than cancer are less likely to receive palliative care. This means it's those people who are more likely to be dying in unnecessary pain without the relief and support of palliative care. So again, I think until we have a situation where access to palliative and end-of-life care is freely available on the NHS to everyone equally, there is a risk. I'm flagging these as risks. I think that is also reflected in the public opinion we heard from Bobby, saying that those, nearly half I think it was, of those supporting assisted dying said they would switch to opposing if someone's choice to have an assisted death was motivated by lack of access. My third and just briefly final point, I guess, that I have been sort of considering is the detailed public opinion work, is that the public don't fully understand the difference between palliative care and assisted dying, and that really worries me. So I think it was a 2021 Survation survey where more than half of people thought that assisted dying meant types of care that are currently legal, such as providing hospice care or the right to stop life-prolonging treatment. And again, in the data, I think, from today, less than half of people understand that it is legal currently to receive medication to relieve symptoms, even if this medication could hasten death. And conversely, people don't understand palliative care, and there again, there's a stark variation in relation to ethnicity. So again, I think any simplified argument claiming that the majority of the public support it when they don't really understand what it means is perhaps not the strongest grounds for me as a representative to vote. So it's therefore upon me, it falls to me and my fellow parliamentarians, and I look forward to hearing my colleague from across the House, when asked to vote on a matter of conscience, actually to weigh up carefully the evidence. As we've heard, it's not only about robust legislation, but it must be about implementation. So is this the right time? Is this the right context? Given the social care crisis, gaps in end-of-life care, are the right safeguards in place to implement this equitably? So to this end, I'm going to continue to listen to the views of healthcare professionals, hospices, people and their families, and the evidence from research. We must ensure that in making this decision, we're not just voting with our hearts, but also with our heads. Thank you.
Thank you, Anna. And Ben.
Thank you, Gareth, and thank you for inviting me to speak at this very, very timely and important panel event. And it's great to see just how much support and attendance we've got this evening. So my name is Dr. Ben Spencer. I am the MP for Runnymede and Weybridge. I was first elected in 2019. I'm also a recovering consultant liaison psychiatrist. That was my profession before I became an MP. I guess you never really stop being a doctor, but it's been a while since I last practiced. And when I was working as a psychiatrist, my academic area of interest, which I did a PhD in, is around decision-making capacity, and specifically what I looked into was decision-making capacity in people with schizophrenia, looking at different types of decisions, research versus treatment. And my very strong area of interest prior to being elected was around treatment in the absence of consent and the legal frameworks around that, and worked with colleagues on this panel in terms of doing this work. And I want to say from the start, this is a really sensitive and difficult area. I know a few panel members have already made that point, but I just want to frame it a bit more. Because I know for a fair few people, certainly people who have contacted me in my years of being an MP, a lot what informs the public debate is relatives who have had a close loved one go through a very difficult end-of-life process, which hasn't been what they would have wanted, and it's been dreadfully traumatic by all. And so I'm very mindful that there is, I think, thankfully, a small cohort, but a cohort of people for whom this is deeply, deeply personal in terms of the experience that they've had. And I just want to just recognize that from the start, because I think sometimes you can get very easily, or at least I am going to, get very focused on procedure and law and the practicalities, but I think we just need to just remind ourselves that that's not to neglect the sensitivity that that group in terms of people have gone through. On the converse, people who have deeply held religious convictions, who equally feel that we shouldn't go anywhere near discussing this, and that it is an affront what is going to be debated, and those views I also very much respect. So I think it's important just to set it from the start. And I myself personally have said to my constituents, you know, before if this comes back, and it has come back, I'm going to survey, I'm going to reach out to stakeholders so people can get their views known to me, and that's what I hope it's gone out now today in terms of my patch. But I've been on a bit of a journey on this. If you'd have spoken to Ben Spencer 10 years ago, and I was part of that panel, I would have been on the strongly support, absolutely strong support. You know, my own personal moral ideology is very much hard autonomy, freedom of choice, etc. And over the course of training as a psychiatrist, doing research, doing capacity assessment, I've moved very much to the tend to oppose position. And there's a few reasons for that, which I'm going to go into. Fundamentally, for me, it's around the implementation. And the more you go into the detail on this, I think the more problems there are. And I really want to see these problems and these details debated. What I hope doesn't happen on the 29th of November is that we have a debate about should we have assisted dying or not, or what I'm going to call is physician-assisted suicide. We need to debate on the detail, because the detail is what really matters, I think, in this issue. Firstly is on the framing. I'm going to call it physician-assisted suicide because it is physician-assisted suicide. Yeah? This is somebody asking somebody to kill them. And apologies for being blunt, but this is what it's about. Can you give me something that will end my life so that I can kill myself or go through that? It is not about assisting the dying process. It is about assisted suicide. And it's particularly for people for whom that is a difficult thing to do in terms of access. Focus around people, let's say, you know, with motor neuron disease, where it's more difficult to get access to end one's own life. People can withdraw treatment. They can refuse treatment. It's not, people can refuse life-sustaining water and food. These are not pleasant things to do, but these options are available to people. So this is about medicalizing the death process and about a degree of choice and control. And I think this framing is very important when we start looking through the laws and the safeguards and procedures around it. As has been proposed, the Falconer, and although we don't have the text of Kim Leadbeater's bill, it's presented with restrictions. So one can only have access to this if one has a terminal illness. And there's a bit of debate around how many months of life expectancy, or whether undue suffering and exclusion criteria. Now, the problem that I have with this, and I go back to almost an ideological autonomy point of view, where you could make an argument where, as a fundamental autonomy right, people should have access to this. So the question then is, well, why are you going to limit it? Yeah, why should you limit it to terminal illness? Why shouldn't children have access to this? Why shouldn't people with cognitive impairment and dementia have access to this? Why is it terminal illness that has access? Is it that people with that terminal illness group have stronger autonomy rights than those other groups? Or you can make the counter-argument, which is actually the protections and safeguards that we give to other people are less important in that group, which is hard discrimination, I would say, on the face of it. And so these things, if one's going to restrict it, or whether you restrict it for all, need to be thought through the consequences. And I attribute Kim Scott for pointing this out. So maybe watching it on over the TV. But he talks about every restriction inevitably moving the boundaries where this has been brought in, because you can't escape that fundamental equalities question. And then there's the issue about gatekeeping. So I really rile. And this is, thanks to, Alex and Gareth's work and Antonia's work on this, well, Clad's work on this, the idea that this is being presented as a medical treatment option. Yeah, medics do not prescribe death. And I think I'm sure most of the medical profession, when you look at surveys, don't want to be involved with this sort of stuff. I think we shouldn't be talking about this as a medical option of repertoire. That's something like Professor Catherine Sleeman could offer to patients. There's an issue around that. And if it's going to be done, I think this really should be sitting with the courts and judges rather than getting anywhere near medics. Because it does, then you start having those real difficult conversations about what is the role and responsibility here. The idea that capacity tests can be a gatekeeper for this, I think, really is for the birds. Yeah. It is very difficult to do a capacity assessment on someone who's agreeing to an intervention. Yeah, and those who do capacity assessments know that. Those are the most difficult capacity assessments to do in the context of consent, because you get what's called an epistemological problem. How do you actually know what's really going on in the person's head? Ben, you've got this awful illness. You've come to me wanting physician-assisted suicide. Yes, I have, doctor or judge. I've all these problems, I've thought it through, I promise I'm not being coerced, etc. This is what I want. How do you dig into that? How do you dig into what's going on? And so capacity tests are not going to pick up or detect coercion in this context. And I think coercion, either subtle coercion direct, which is pretty obvious, or indirect, is not going to be detected by this process. And I think that needs to be thought really carefully. The cognitive test, the cognitive ability to understand what death is, and let's face it, on one hand we all do, on the other hand we all really don't, is actually a very simple, straightforward test. So I don't really understand, apart from detecting people who have quite substantial disorder, and the only thing I can think of actually which would block a capacity assessment in the absence of coercion is where someone had a delusional belief where they could not possibly die, or something like that, or some sort of really odd thing. I can't see how a capacity test is going to act as some sort of gatekeeper on this. It may be that this stuff doesn't matter. It may be that all this detail really, at the end of the day, we think it is so important as a moral good that physician-assisted suicide is available for people. The safeguards are sort of neither here nor there. Yeah, and we accept and we tolerate the fact that there will be people whose decision is moved by 5 or 10% probability to choose physician-assisted suicide rather than quality palliative care or whatever, because of feeling that they're a burden or other stuff going on. As a society and as Parliament, I think that sort of stuff we need to think about in terms of what the moral hazards are and where we come down, in addition to the detail about how this works in practice. I do hope, one of the problems with a private member's bill is that it doesn't have the research and backing that a government bill does. And so I worry, while Kim's been very well to get this debate going, I wish it wasn't being debated as a PMB. I wish it was a government bill with a serious amount of research, with a decent amount of time, rather than 5 hours or so to debate the second reading on the 29th. Proper research, law commission, all the badges and whistles so we can get dug into it. Because I think what we all would agree here is let's have a proper debate about it. Let's scrutinise it, and if we're going to do it, let's get it right. And let's make sure we're asking the right questions. I worry we may not see that on the 29th, but I hope I'm wrong. Thank you.
Thanks, Ben. Sonia.
Great, thanks. Well, hello everyone. My name's Sonia Soda. I'm chief leader writer and a columnist at The Observer. One of the great things about going last on a panel like this is that nobody has left you anything to say, so you can be short and sweet. It's a fantastic panel to be on. I think the quality of debate is some of the highest I've heard around assisted dying or assisted suicide, whichever you want to call it. And to be honest, I think I agree with pretty much everything that's been said on this panel so far, which is a bit of a record when you're used to doing these panels as a journalist. So I'll try and just focus my comments on things that I can pick up on that maybe others haven't had time to. So I suppose just to introduce myself and why I've ended up writing about this topic, I've been on a very similar journey, maybe to quite a few of us, but certainly a similar journey that Alex and Ben might have been on through my own work. So again, 15 years ago, if you'd asked me what I thought about this, I'd have been like, yep, tick, I'm a good left liberal. Of course, I believe in autonomy and choice, and assisted dying seems to go alongside all of my other beliefs. And really, the thing that's made me think again and rethink my views on it quite hard is, as a journalist, I've done a lot of work on coercive control and domestic abuse on the one hand, and I've also written a lot about safeguarding issues, particularly in relation to children. And that's really changed my perspective on the world. I think 15 years ago I was pretty naive, actually, about human relationships and how they were, had quite a rosy view of the world. And it's through my journalism in these areas that you realise that actually human relationships are far, far more complex than you might be able to understand through looking at your own relationships in life, and that very few people have the sort of ideal when it comes to sort of family and personal relationships. A lot of people have, great things about them, less good things about them, and there are some people who are in very, very difficult situations, including coercive control. So one of the things that I would pick up on, I share so many concerns on the panel. The areas that I will add is, first of all, I think there probably will be a gendered aspect to this. And I say that as a feminist and somebody who's written about coercion and domestic abuse. We know that coercive control is a gendered phenomenon. We know that 1 in 3 female suicides, coercion from a partner, is a factor. And it's kind of like, how can we be talking about assisted suicide without bringing some of that knowledge into the debate? We know that 1 in 5 older people, according to charities, older people's charities, have experienced some form of older abuse as well. So I think these questions are very important. And for me, I think there's also a question around consent and what does consent mean? What does capacity mean? One of the things that I struggle with is that as a society, we do so much around suicide prevention and we acknowledge that that is a good thing. And then when we're talking about mental health and people who might be suffering from mental health issues alongside terminal conditions, and Catherine will know this much better than me, of course, but one of the things that palliative care specialists say when you talk to them is that actually depression is quite common, a common reaction to a terminal diagnosis, but that within a couple of years, your mental health outcomes are pretty similar to the general population. So, what does that say about a point in time? And is somebody who is suffering depression at the same time as a terminal diagnosis? How do we define that? Can they express consent? I don't think we've worked out any of that at all. I also agree that opening up this question will lead people to say, well, why aren't we doing it for X, Y, Z? Because it is a question framed and an argument framed in autonomy. But one thing I will also add is that I think that proponents of existing proposals say that they are very, very limited. But actually, I don't think a 6-month terminal diagnosis with 6 months to live is necessarily that limited. I think it will end up depending a lot on the doctors who are signing off. Again, in my conversations with palliative care specialists, including Catherine, they said to me, it's very difficult to predict how long someone is going to live beyond days. So actually it becomes really up to a doctor's judgment whether it's 6 months or a year. And so these categories can actually become incredibly expansive, and that's one of the things that we've seen happen in Oregon, where anorexia and arthritis have been defined as terminal conditions in some cases. I also think that there's a bigger philosophical point, which is around how we view people who are suffering from serious illness or he may be incapacitated in some way, or he may be living with a disability. And at this point, I do need to shout out to Liz Carr, who is in the audience. I really, really recommend that everyone watches her documentary, Better Off Dead. I think regardless of how you come at this subject, it will profoundly affect the way you think about this issue. And it certainly did for me, even though I thought I knew what I think. So I think it's a very powerful piece of documentary that I recommend. But, you know, one of the things it makes you think is once it becomes a possibility in society for someone to end their own lives with the sanction of the state because their lives involve a lot of pain, that involves judgment from the rest of society. And how do we stop this affecting the way that we socially see people with disability? I really don't know the answer to that, and I'm very worried about it. Just the final sort of points that I would like to end on is I have massive, massive concerns about process. And this is I think it's one of the most complex, ethically complex issues that I've ever written about as a journalist. And I have written about some other ethically complex ones too. But it's one for me where the more you think about it, the more you realise just how difficult it is to get answers and to think through answers to these questions. What are safeguards? I've been incredibly disappointed, actually, I've read through a lot of the parliamentary debate that's happened on this to date around other proposals. There are some excellent parliamentarians who, whichever side of the debate they're on, they get that it's complex and they get that it's not simple and they get that it's not a case of good v evil, but there are lots of parliamentarians, I'm sad to say, who do seem to take that view. Obviously not Ben and Anna, and it's fantastic to share a stage with two such thoughtful parliamentarians. But my concern actually is that not all parliamentarians are like that. That's very evident when you read through the debates. And some of these issues have not, even though we've debated assisted dying or assisted suicide quite a few times in Parliament, these issues some of them have not been posed properly as questions, let alone answered. And I'm very, very worried about that. I also think that the process of doing this as a private member's bill is extremely problematic. I can't believe that Keir Starmer wants Parliament to be making a decision on this, regardless of his own personal views on this, without significant pre-legislative work. It beggars belief to me that we are on stage asking these questions. We've just had a bill with a first reading and the Prime Minister is saying, I want Parliament to be able to vote on this. It's really important. And we've not had these questions answered. I mean, the idea that you would do this without some kind of royal commission, without some kind of Warnock committee, you know, perhaps it could be, a law commission project, although I think it would need to draw in a greater range of expertise. But there is now a lot of evidence internationally, and our understanding of it simply isn't good enough. And it worries me that people want to debate this in Parliament without doing some of this work, because it says to me that actually they don't really understand the issues at stake. So I am very, very concerned about that. And probably just a final point I would end on is, you know, we've had this debate around medical professionals versus judges. I don't think judges or medical professionals are particularly well placed to spot coercive control. I mean, medical professionals aren't trained in coercive control. And actually we know judges get coercive control wrong in the family courts. We know that through appeal judgments. And assisted suicide is something you can't take back. Once you've done it, you've done it. And I do think that actually, in the most recent House of Lords debate, Lord Neuberger, I said something that I kind of admired him for his brutal honesty, because he said, there will be abuses. You know, he said they would be occasional. I actually don't think that you can know that. Don't think you know the balance of cases where this goes well versus where there may be abuses. But he acknowledged that there would be what he termed occasional abuses. That is state-sanctioned wrongful death. And for me, it's quite difficult to think about, well, how many state-sanctioned wrongful deaths are okay? I really get the arguments on the other side of the argument. I get that it's you know, I would want an assisted death for myself if I had the capacity to consent to it. I don't think that that's something parliamentarians should give me, because I don't think that we know what those safeguards would look like. So, yeah, those are just some comments from me.
Thanks, Sonia. Well, if you're worried about going last, all I can say is, what were you like when you're first? Wow, that's some amazing, incredibly interesting, or 5 short speeches or sets of remarks. So we've got some student ambassadors, I think, here with microphones. So just while you're collecting thoughts, questions that you want to ask, I might just ask the panel whether there was anything that you heard other panelists say that you wanted to talk more about. I thought that was a very interesting provocation, Sonia, you made about whether, doctors are maybe difficult in this area, but so are lawyers.
But they're not inherently, it's an existential question.
Yeah.
And why do we think any better place to identify? I mean, over and above the coercion aspect addressed by Sonia, the more deeper question is, who is better placed to decide that someone really, really wants to die? And what happens if they really, really want to die for apparently the wrong reason? What do? Discuss. Could I please just also flag very quickly, if you want to see an example of how to do this properly, please look at Jersey. The amount of money, the amount of resource, the amount of time, and the 384, whatever it is, pages of the proposal worked out this is what it would look like, complete with scenarios at the back of here are a load of different factual scenarios, and then you can put yourself in the shoes and work out what you would do. And that is the sort of thing, it's brilliant to have Anna and Ben on this panel. I think you're radically under-supported by not having that material in order to be able to go, this is what it looks like.
I agree. That's okay.
Anna, did you want to come in also as a non-doctor and a non-lawyer?
In terms of reflection, you know, I knew that this was a complex debate. I had my own sort of views on sort of some questions. I think the panel have added further to the many questions. I happened to I had a visitor in Parliament today from Jersey and did hear a little bit about the process that's happened there. And I suppose my reflection is that I also feel quite nervous that a private member's bill, I mean, I'm new to Parliament, but, you know, doesn't allow full time. I vote on lots of things in Parliament, and I trust that there's been legislative scrutiny, that, you know, there have been impact assessments done by civil servants, that there's all sorts of work that's been done to make sure that the evidence, the impact assessment, everything is brought together. My understanding is, that doesn't happen with private members' bills. And so we're sort of being invited to vote on a principle when actually the real issue that will help me make my mind up is all of these other implementation issues. And it feels difficult, as people have said, and I think it's just been heightened by hearing the other panelists, I feel quite naked, I suppose, and exposed as a parliamentarian, being asked to make what is probably the biggest decision I will ever make in however long I sit in Parliament, because it is on me. You know, it's not following a whip. It's not somebody else. I've got to be informed about this myself. And it does feel, however many great events like this there are, and however much, you know, people like Ben and I, as conscientious MPs, will go back and we'll have conversations in our constituency, that we are skimming the surface of the depth of issues that those of you here who've been spending much more time over many, you know, decades on it, have raised this evening. So I think, if anything, you know, the sea of complexity that Bobby put up there, I'm like, okay. It is a lot to try and consider in a relatively short amount of time.
Okay, so it'd be good to bring in some people from the audience. Yeah, so should we go to this gentleman here in the checkered shirt?
Thank you very much. A very interesting debate. I'm a retired medical doctor and have run an end-of-life clinic in a hospice in North London, and currently run an end-of-life clinic in a GP practice in North London. And 2 points come up, and that is, it's about time we did research on people who have an end-of-life condition to find out what they feel about it. Because it's been over many years said that the people who should be making this decision are people who have an end-of-life condition and are coming towards the end of their life. The second point, which I think is almost more important, because the end-of-life clinics that I've run have clearly been about lasting power of attorney and advanced decisions to refuse treatment. They have not been about assisted dying for the terminally ill. And the thing about that is that there have been conversations. It's not that they walk into the room, you sit for an hour, have a conversation, and they walk out. It's an ongoing discussion. And therefore, talking about assisted dying for somebody who is in the process of dying is not a one-off. It happens over time. And because it happens over time, and generally with the family, I think one has got quite a good idea about the validity of the discussion which is happening. Thank you.
Yeah. Thanks for making that point. Yeah, more of a comment and a thoughtful, important one. Shall we go to this lady in the red here, and then we'll...
Thank you. I've been a nurse since 1974, so you can work out I'm and I've worked in palliative care settings and also lots of other settings throughout my career, and I continue to do this without doing anything terribly useful, but that's another story. It does occur to me in all of this, and I'd like to hear what the panel think. We live in a society where we don't actually talk very much about dying and death. We don't know very much about it because we've removed ourselves from it. If anybody in our family or a loved one or whatever is likely to be dying, they're probably going to be shipped off to a hospital where they can have the joy of dying in a corridor. But again, that's another story. But we never discuss it, really.
Should we ask the panel?
Visibly. So
yeah.
That's really what I'm asking about. And I'll give a plug for Catherine Mannix's book, With the End in Mind.
Thanks. Who'd like to take that quickly? I mean, that's such an important question, isn't it, about discussing dying as a kind of cultural thing. Catherine, you must have obviously lots to say about that.
Yeah, I'll keep it quite brief. Yeah, you're absolutely right. We don't. Dying now happens increasingly behind closed doors in hospital and other kind of quite sanitised settings. And that means that people have lost touch with what normal dying looks like, what ordinary dying looks like. And actually, I think this whole societal debate is sort of encouraging us to lose touch with that as well, because most of what we hear now in the media and read in the news is about the very, very terrible stories about people dying in terrible ways. And actually, you know, I completely agree. Every one of those stories is a tragedy, and that's someone's family member, someone's loved one. But that's really, really rare. And actually, ordinary dying doesn't really look like that, and we have lost touch with that, I think.
Could I make a very quick plug while Gareth's choosing the next question? Please read the Lancet Commission on the Value of Death. It's just brilliant. So important.
Yes, let's take your question. Or comment.
Yeah. Yeah, a couple of observations, particularly in relation to Catherine's comments. I'm married to a Canadian doctor who works at a Dutch university, so I had an opportunity to think about this quite a lot. I also was the founder investor in what I believe is the largest psychiatric service in Europe today. We employ 300 consultant psychiatrists, and I want to talk a little bit about capacity. We deal with about 250,000 patients a year. We employ 300 consultant psychiatrists, and we work with 150 plus what used to be called clinical commission groups, now integrated care boards up and down the country. We heard from Catherine in South London, there's a patchy service, but in places like Cumbria and Cornwall, they dream of the facilities available in South London. Even for clinically straightforward cases like ADHD, lists. We've taken over lists of 3,000 people who've been waiting for an average of 7 years. On the Isle of Wight, there's not a single consultant psychiatrist, not one, for a population of 500,000. So this issue of capacity is really, really important. In the Canadian context, MAID now accounts, MAID is the Canadian assisted dying program. It accounts for 4.3% of all deaths and is growing at 30% plus annually. And I've read cases in Saskatchewan, where my wife is from. I don't know quite how much urban myth there are, but they're in the newspapers of people who've gone to see their doctor because they're depressed and they can't make their rent, and they're offered assisted dying. So I really worry about that mission creep element of it. There is a tiny, tiny fractional proportion of doctors we know from Shipman who are psychopathic, and they will be drawn into areas like this. And finally, I also want to strike a note of optimism. AI is accelerating medical science so rapidly. We just saw yesterday Dennis Hassabis getting the Nobel Prize for discovering 50 million proteins, which was considered to be something that's only going to be available in 50 years' time. And I think that we should desperately hold on to life. And diseases which are fatal today might not be even in 6 months' time. So this 6-month limit, I think, is really something we should give consideration to. Those are my points.
So, comments really, but very helpful ones.
In the corner as well.
Yep, sorry.
Waiting.
Yeah, let's take you over there.
Sorry, to make this ambassador sprint. Getting a step count up.
Thanks very much. Hi, yeah, I'm interested in the concept of autonomy in relation to this, and I'm troubled by it being framed as an autonomy and discrimination issue, as if it's about allowing people who are physically incapable of committing suicide the autonomy to do so. And you can only frame it in that way if you describe it as suicide, which one of the panel members did. But it isn't suicide, it's being killed by somebody. And that's a completely different moral issue. It's not a matter of discrimination if you frame it as that. Nobody has the right to ask someone else to kill them. So it's not, to me, it's not a matter of autonomy because of that. It's not, I don't understand why it's framed in that way at all. I wonder if the panel have any reflections on that. And also I wonder if there's anybody here who's in favour of the bill.
Okay, thank you very much. Ben, do you want to take that question?
Yeah.
So I think I used both terms in terms of being killed by someone and also suicide. I'm coached in those ways because it depends on how it's going to be. I mean, we don't know how it could be rolled out. We don't have the text of the bill, but I can imagine two scenarios, yeah? One where you've got somebody who has a terminal illness but is physically incapable of carrying out an act which would end their life, in which case they may request for a doctor or whoever to give them some sort of treatment or some sort of intervention. So I shouldn't have used treatment, but an intervention which would end their life. So I think on that basis, that is somebody who is killing somebody, but we can debate that. Sorry, I don't mean that in a dismissive way. That's the way I sort of think about it. Or do you have a context where somebody wants to have access to a intervention, which then they take themselves, which they end their life? And so one could argue in the first case, this is more about autonomy rights of somebody who is being denied the ability to end their life because of the effects of their illness. In the second case, you could say this is more about around access to ending one's life in a particular way and particular context as a sort of choice in terms of how one wants one's life to go and one's life to end. And I think we have to keep on going into the nuance and the detail of these cases, because I think context is really, really, really important, and these scenarios in terms of what's going on. What we see in the media is people such as Esther Rantzen, who is framing it very, very much as a fundamental autonomy right, my right to choose, and around control over the end of one's life. What I worry in terms of this debate is that people such as Esther Rantzen in those cases have a lot of sway and they get a lot of focus. Well, I think the focus shouldn't be on, look, I mean, hey, are there situations where choosing death over life is a good idea? I've been a doctor. I've looked after patients when I thought, you know what, hey, things are really bad. I think, dying now would be, if that happened, that would be a good thing, and, etc. So of course there's situations like this, but this is about medicalisation of the death process. It's also about control, and the cases that we need to be talking about are the example, let's say someone who's got mild cognitive impairment, not sufficient to knock out their decision-making capacity, who's got a terminal illness, who has substantial social care needs, which is putting pressure on their family in terms of visiting them, in terms of their thinking about inheritance to their children. Perhaps kids are being taken out of school because of family and family breakdown, and all this social morass and horror, whose autonomy decision is it time for me to end my life, moves from 40% to 60%, because of the availability of physician-assisted suicide. And I think that's what we really need to get into the nub of. What are the safeguards? What are the issues? What's going on there? How we can make sure we detect that or protect it? Or, as I said at the end, is it that we think this is such an important autonomy right, those cases don't really matter? And we're willing to accept that. But that's why we need the research, and we need the impact assessments, and we need that sort of piece of work.
Can I just come in quickly?
Yeah.
I do think there's an important dimension of this debate, which is about power and power of voice as well, which I think a lot of us have alluded to. And one of the things that I guess profoundly depresses me about the nature of the debate, but also the campaign for this, is it's really hard to get the most, and I'm not talking about Esther Ransom, because I think people for whom this is very personal, obviously they want to go out and talk about, on the news about it, because it's literally their life. But it's the job of parliamentarians and campaigners to mediate those voices and to understand those aren't the only voices that count in this debate. And actually, I would probably disagree with the gentleman who said we need a lot more research with people with, with end-of-life conditions, because actually I don't think it's not just their voices that matter. It's everybody's voices in society. My concern is that there's lots of people who aren't represented in this debate because they don't have a voice. So, for example, the women in coercively controlling relationships who, if they ever got a terminal diagnosis, there would be a lot of undue pressure on them to end their lives. Those people don't have voice. And I just think I can't quite believe how little the campaign has moved on and how little give there has been. It is still being framed as this is good versus evil. This is people who are morally compassionate, who have understanding, and people who are just a little bit cruel or a little bit backwards or a little bit religious. Not that there's anything wrong with being religious, but the concerns are so much deeper and more complex than that. And it raises a real red flag to me, because when you try and have a conversation with campaigners who are very, very pro this, some of them are not able to concede any ground. And that is very difficult, and that raises real questions about the extent to which decision makers and people who are involved in this debate in public are able to acknowledge the complexities and get onto the how rather than just the moral principles. And I'm really, really worried about that. I think this is a debate that's playing out in a very black and white social media age, and it could go disastrously wrong as a result of that.
Okay, we're going to take a question.
Thank you. My name is Lizzie Collins. I'm the Member of Parliament for Morecambe and Loonsdale, so I will be one of the people voting on this bill. And I came here tonight because even though I have a fairly settled view on it, I wanted to be challenged on that, Anna. And first of all, I think I wanted to reassure Sonia, in terms of the nuance of the debate, actually that is being discussed. I'm having a lot of individual conversations, and I'm very open about what my views are, but I'm having a lot of individual conversations to try and draw out that nuance. And I don't think it's beyond the ken of Parliament, and I don't think, despite all the very good questions that have been raised, and the questions that do need to be talked about, I think we have to be careful not to misrepresent the debate. And also, I really don't think it's beyond the ken of Parliament to make these sort of decisions and to do it well and to get statutory guidelines in place that answer those questions. And if it is impossible, then we're in a bit of trouble because Parliament makes life and death decisions all the time. Whilst this, I think, comes across as a very unique debate, actually it's not as unique as you think. And it worries me. One thing that does worry me, and I'd like the panel's view on this, is that I go to events and they can be presented as a balanced view, and actually the panellists appear to be going on one side of the debate. And that concerns me because instead of, because as a parliamentarian, what I want to see is a bit of back and forth and a bit of, well, this is my question, well, this is my answer, this is my challenge, this is what I'm coming back with. And I do think that is what is missing currently, and I worry about that. But the individual conversations that are happening around Parliament are very deep. Now, my personal view is, I think, different from the panel's. If a well-drafted bill is brought to Parliament, I'm minded to vote for it. But I think let's have this conversation in the round. Let's not have different panels giving different arguments, giving different sides. Let's actually have it all together. And that's what I would really like to see. And I wonder if the panel would agree with me on that.
Okay, anyone want to pick up on that?
Yes, of course. But I suppose one of the things I would say is that I've tried to talk about these questions with people who are strong supporters of assisted dying, and I've never got anywhere on these answers. And I guess my question back to you would be, I don't think it's impossible for Parliament to do this well. I think doing it through a private member's bill is going about it in the wrong way. And so I guess my question back to you would be, given the number of questions the panel have got, the lack of evidence on this, the lack of really good look, would you agree that a private member's bill is the wrong legislative process to put this through at this stage?
I don't know if it's fair to whether Lizzie wants to come up with it or not.
Should we? Do you want? Is there? I mean, we're going to have to wrap up now soon because we're running out of time, and it's important that we have a time for a drink. Because we're going to need one. Anna, do you want to say something?
Because I think Lizzie and I like it is really important as parliamentarians. One, we have really safe space to debate these issues. It is unfortunate because it is happening in a lot of one-to-one conversations, and the rooms I've been in so far have either been very for or very against. And actually, I was coming to this panel because I was really keen to hear ethical, practical, from people in palliative care, legal opinion as to what some of the questions we need to take away and answer. And I think there really is a question just of the amount of time and the resource. That is my concern, to make sure that, not because we're not asking ourselves the right questions, but actually we're not necessarily being well supported to really get that depth of answer and support, to make sure that it's not just about, as I said in my comments, a well-drafted piece of legislation. I mean, I think there are people around and people supporting this who can maybe make sure that, but actually it's never going to be on the face of the bill, all of these things about the implementation. But it's this sort of cart horse thing, and I feel like there are risks of voting on even a well-drafted piece of legislation that actually so many of the things are left to implementation. And I think, as we've seen in other countries, actually it's where, the implementation happens, and some of the issues that have been heard today. So I think, I'm not going to speak for Lizzie, but I think there are a lot of us in Parliament who are having these conversations, but we're trying to do them sort of in the wings of actually a very busy parliamentary programme, being new MPs. A lot of us are new. It's been quite a steep learning curve. I think there will just be a feeling of have we really been able to bottom everything out that we feel is necessary in order to be confident? And I suppose, in the sort of full transparency, I've written a book where I was quite pro in my book on the age of ageing better. I guess through some of the work I've done with Catherine, I've got more sort of questions given the context. And, I think from other things, we go for the precautionary principle. If we're not sure, then better not. And I think that's where I'm personally leaning. But because I don't feel that we've got it well informed. So there's a bit of transparency to you guys, you interested as legislators, that's some of the reality of how it is in Parliament at the moment, and how we are taking time for this, but we need more help, so please more of
Okay,
this.
now I'm going to have to wrap this up.
Sorry.
Can I say one?
No, I'm going to have to wrap this up, Catherine. I'm sorry. There's just so many hands, and this conversation is going to continue. But the thing is that we've got at the end here is a conversation between MPs, and I think that has to be important because, I mean, you guys are the decision makers now. So Ben, do you want to have a few words as an MP?
I'm just going to say this very, very briefly, because I totally get there's been a couple of comments raised about sort of views in the panel and sort of taking one position or another. From a fundamental point of principle, do I, in terms of the way I look at the world and my hard views on autonomy, do I think people should have the powers to choose how they end their life if they can? Absolutely. That's my sort of base position. So my sort of moral, ethical core is pro something like this. My big problem that I have with this is implementation and reality. And this is a change that's happened to me from before I became an MP to afterwards. Because as an MP, we've got to make laws that work. And that the consequences, to a large extent, we can foresee. And I think that's the problem with this era in debate. And I think it gets focused on principle, when really we have to look at the detail in terms of how this work or how it won't work, and then have a principle argument based on what the offering is after you've exhausted that process.
Okay, well, this is fascinating. We're going to be seeing Parliament in action, and parliamentarians. Let's hope, like the three we've heard from tonight, really considering this in depth. I think the question for me that's come out of the panel discussion here is not so much pro-anti, but the readiness question. It's more about a readiness question. And ultimately, you're going to have to decide. This is the moment for parliamentarians, which is I think something we all support and agree with. So, fascinating discussion. I'm going to draw things to a close now, but just to end with a few things about what next for the Complex Life and Decisions group. And as Bobby said, we've got really quite a lot of interest in deliberative methodologies. There's much more to do. There's much more to do on understanding NHS staff and the delivery, the implementation questions that that Anna's drawn a lot of attention to. And you can do those deliberations in dialogue, in fact, with the public. So we take the view that there's a lot, in fact, to learn from public deliberative exercises, and there's much more to do with them. There's big questions around palliative care provision. We've talked about the patchiness of it across the country. Catherine's question is what's good? What does good enough look like here? We don't really have a sense of, we haven't calibrated an answer to that question, which comes around, I guess, to the big parliamentary question: are we ready? Is it looking like it's safe enough? Now, there are lots of other things to talk about. This is a bill that's quite restricted in many respects. It's not going to take in neurodegenerative diseases in any meaningful sense. So the big debate about that, which includes dementia, is really not being had yet, and probably needs to be had, and deliberative exercises can feed into that, we think. Now, there's just one plug for our next event, which is going to be a joint event with 39 Essex Chambers, which is a law chamber specializing in mental capacity law. Alex here, and we're going to dive into some of the nuts and bolts detail here on the law, particularly looking at capacity. And we think international comparisons there will help us pick apart some of these issues. So that's enough from me. Thank you very much on behalf of the Complex Life and Decision Group, the CLAD group as we call ourselves, and particular thanks to our panelists who've given up their time to come today. The MPs, straight from Westminster, amazingly impressive. Thanks for doing that. And of course, all of you for your thoughtfulness and contributions this evening. So. And we have a website, just finally, we have a website which I think is in the pack, So look out for news and events there. November is the next one.
Yeah, we were just trying to nail it down.